Hello, my name is Milind Desai. I'm a cardiologist and vice chair at Heart Vascular Thoracic Institute at the Cleveland Clinic, and I shall be discussing the results of ODYSSEY-HCM trial. ODYSSEY-HCM trial tested the strategy of mavacamten versus placebo in symptomatic non-obstructive hypertrophic cardiomyopathy patients because, as we all know, there are no proven therapies to treat this condition, and it remains an unmet medical need. So this was a phase 3 multi-center international randomized controlled trial conducted at 201 sites. It randomized to placebo or mavacamten, symptomatic non-obstructive HCM patients. These patients were diligently ruled in for non-obstructive HCM by excluding latent outflow tract obstruction as well as excluding the phenocopies. And after a screening period of 35 days, they were randomized to mavacamten starting at 5 milligrams or placebo and then followed for 48 weeks. The primary endpoint was a dual endpoint of peak change from baseline to week 48 in peak VO2 and change from baseline to week 48 in KCCQ, Kansas City Cardiomyopathy Questionnaire clinical summary score. Additionally, we also analyzed biomarkers, various echocardiographic markers, symptoms, as well as additional quality of life metrics. Plus, safety events were ascertained and monitored. So, in terms of the primary analysis of change from baseline to week 48, the dual primary endpoints failed to reach statistical significance. Based on the statistical analysis plan, we did not report the additional analysis in the primary manuscript. Having said that, there was a pre-specified analysis on biomarkers which showed a 58% reduction in NT-proBNP and 51% reduction in troponin I. Additionally, there was also directional improvements in diastolic function as well as wall thickness on echocardiography analysis. The primary manuscript is published in New England Journal, and the 2 secondary manuscripts were also simultaneously published in JACC. In terms of safety monitoring, what we found was 1 in 5 patients in the mavacamten group had reduction in LV ejection fraction to less than 50%, which was reversible following interruption of mavacamten. Also, 19 patients had congestive heart failure admission in the mavacamten group, of which only 5 were in the setting of ejection fraction reduction less than 50%, which was reversible. There were no other additional signals in terms of atrial tachyarrhythmias, etc. So at this point of time, because the primary analysis results were neutral, it is not going to make it to the guidelines or to the regulatory agencies for obvious reasons. But it does provide us insights that there are some directional improvements happening. So ongoing responder analysis is going to help us decide which subgroup of non-obstructive HCM it may be useful in. So that thought process is ongoing. I mean, there are a few questions that come up in this, should we start the therapy a little earlier? Should we continue it a little longer? Should we dose titrate in a different way? Should we look at alternate endpoints? So all those things, right now, the way it stands, it is not a registrable trial. But there's enough food for thought for the future. There is ongoing responder analysis to see which subgroup responds well to this and how can we translate that in the future for new strategies to take care of these patients.